Welcome back to the two-part Tendon and Tendinopathies podcast series, and here we have part 2, Tendinopathies. A multitude of injuries and injury terms are associated with tendons. Tendons and their associated tissues may be exposed to such conditions involving partial or complete tearing at the MTJ or tendon proper, strain or rupture, inflammatory processes as in tendinitis, acute abusive overload as in reactive tendinopathy, chronic degeneration or tendinosis, pathological irritation of peritendinous tissue as in peritendinitis or paratendinitis or tenosynovitis or tenovaginitis, and disorders of the TOJ, including insertional enthesopathies and apophyseal problems such as Osgood-Schlatter's or Sever's disease in adolescents. Although the vast majority of tendon pathologies occur in active sporting populations, there are certain systemic conditions which may predispose sufferers to tendon problems, such as rheumatoid arthritis, ankylosing spondylitis, diabetes, and peripheral vascular disease. Among the most commonly injured tendons are the Achilles, patella, hip adductors, tibialis posterior, biceps brachii long head, supraspinatus, and those at either end of the flexor and extensor muscles of the wrist and hand. Numerous authors in the past decade have stressed the importance of using correct terminology for tendon conditions. These include Cook and Kahn from 2007, Keating and Best in 2009, Rees et al. 2009. According to Keating and Best, tendinitis is an acute injury where there's incomplete structural disruption of the tendon and associated vascular damage. Tendinitis will involve an inflammatory response. Tendinopathy is a broad term which can refer to any condition affecting tendons. Due to the gathering evidence that shows overloaded tendons present with a minimum or absence of inflammatory cells, the term tendinitis, which implies inflammation, is considered inappropriate, unless clinical signs suggest otherwise, and there is histopathologic confirmation. Regarding the development of chronic tendon conditions, Rees et al. State that the inflammation may play a role in the initiation, but not the propagation and progression. Furthermore, Kahn et al. 2002 state that within 2 to 3 weeks of tendon damage, the process of tendinosis is firmly established. Inflammation in peritendinous tissue, certainly in the acute phase, may be more appropriate, hence the terms paratendinitis and tenosynovitis may be applied correctly. However, the peritendinous tissue is also vulnerable to chronic degeneration. Cook and Kahn 2007 explained that tendinopathies primarily affect active people, and the more active, the greater the risk, especially in elite athletes. According to Rees et al. In 2009, certain populations are more susceptible to tendinopathy than others. This may relate to such intrinsic factors as age. Aside from the adolescent apophyseal conditions, tendons in older populations are more likely to show a reduction in proteoglycans and an increase in crosslinks, leading to stiffer tendons, which are less able to tolerate high load stress. Gender, biomechanical alignment, body composition, increased waist-to-hip ratio, and generally high levels of adipose tissue. Blood type, ABO, antigens of blood groups may have influence on the vulnerability of tendons to rupture. Hyperlipidemia, increased blood volume levels of low-density lipoproteins or LDL cholesterol. Flexibility, reduced or increased, and mobility, hypomobility or hypermobility. Nutritional status, previous injuries, tendons are vulnerable to repeat episodes of symptoms, and history of corticosteroid injections. Comparisons regarding the prevalence, incidence and predisposition of tendon injuries in male and female athletes are still flawed. Clayton and Court Brown 2008 explain that simply because more males participate in sport, that more males present with tendon problems. Cook 2003 explores particular factors which predispose females to tendon injuries. Such factors include comparatively an inherently weaker musculoskeletal system with reduced muscle mass, structural differences such as a wider pelvis and the commonly associated increased angle of hip inclination and genu valgus, as well as a narrower shoulder girdle and increased carrying angle of the elbow, and increased body fat percentage. Two other proposed reasons for a generally lower prevalence of female tendon injuries relates to the influence of blood supply. Blood flow through the female Achilles tendons is generally greater than male, and hormonal factors. Also, estrogen is thought to offer a protective effect, which may help to explain the increased prevalence of tendon problems in postmenopausal females. It's important to recognise that females do experience a higher prevalence of peritendinous disorders, such as de Quervain's tenosynovitis involving the tendinous sheath of abductor pollicis longus and extensor pollicis brevis, which can relate to the subset of factors, including those identified previously with additional ergonomic and repetitive stress issues. Generic extrinsic etiological factors for tendon injuries include issues associated with changes in training and loading, apparel, equipment, and training environments. In 2009, Cook and Purdam presented their three-stage continuum model of tendinopathy. Essentially, the model is one of convenience and is designed to allow rational placement of treatments along this continuum. Stage 1 of the continuum is termed a reactive tendinopathy, where sufficiently abusive overload, tensile, compressive or shear stress, which is usually relatively unaccustomed, and this causes a short-term tissue response characterized by homogeneous swelling, where the tendon is swollen but remains normal in structure, and significant localized pain, typically 5 to 6 out of 10 on an analog scale. Cook and Purdam add that reactive tendinopathy can also result from a direct impact, which is a non-tensile and only transiently compressive load. Although reactive tendinopathy is a non-inflammatory cell response, it does feature a short-term proliferative and metaplastic adaptation of cells as tendon cells begin to resemble chondrocytes, and an increase in their cytoplasmic organelles occurs, which in turn increases the local production of proteins. The main proteins produced are larger proteoglycans, which have a faster response than the normal proteoglycans found normally in tendon tissue. These cause a short-term alteration of the extracellular matrix due to their water-attracting properties. This results in the homogeneous thickening and a swollen tendon, odomentus, an increased cross-sectional area which allows the tendon to effectively spread the localized stress. Unless severely excessive overload is experienced, collagen integrity remains largely unaffected, and there's no alteration to neural or vascular structures. Cook from 2011 suggests that pain during this stage, which generally increases with activity, results from the release of nociceptive chemicals. Cook and Purdam from 2009 maintain that reactive tendinopathy has great potential to resolve, often within 7 to 10 days, if managed appropriately. Management must involve relative rest, which essentially means removal of all abusive loading, but incorporate of appropriate loading, optimal loading. Stage 2 of this tendinopathy continuum is termed tendon disrepair, and as the name implies, healing is attempted, but there's evidence of a structural breakdown. Tendon disrepair may ensue due to poor early management, the main issue being repeated episodes of abusive overload, and pain still increases with activity. The proliferative response of stage 1 continues, but with greater numbers of chondrocytes and myofibroblasts. There is a continued increase in proteoglycan production as well as collagen. Greater separation of collagen fibrils occurs and a disorganized matrix develops. This is termed collagen disarray, as well as the ongoing edema. Neovascularity and neural ingrowth occurs as vessels bud into the developing extracellular spaces. Although tendon disrepair may be difficult to confirm clinically, in the absence of ultrasonography, it's essentially a pathological development from initial reactive tendinopathy. Reversibility is likely with appropriate load management. Stage 3 of the tendinopathy continuum is termed degenerative tendinopathy, which many will know as tendinosis. During this stage, structural maladaptation has occurred, with an established disorganized matrix, significant neovascularity, apoptosis or cell death of tenocytes due to exhaustion from repetitive overload, reduced collagen and an enlarged nodular tendon. Changes are focal as opposed to the homogeneous swelling in reactive tendinopathy, and the degeneration will be interspersed with different stages of the pathology in normal tendon. Young, in 2011, describes a process of developing collagen cleavages which become invaded by lipid or fat cells, which gradually begin to harden and are replaced by calcium deposits, leading to a calcified, localized stiffness. The athlete may describe an ongoing grumbling type of pain, which may undergo periods of ease and aggravation in response to load changes. Degenerative tendinopathy is more prevalent amongst middle-aged and recreational athletes. When degenerative tendinopathy is evident, as mentioned, it may not necessarily be a continual daily painful problem for the individual, but it can be easily aggravated, leading to what in essence could be described as a reactive tendinopathy within a degenerative tendon. The degeneration and associated stiffness and weakness in this stage can also leave the individual at risk of a complete rupture. Cook, 2011, explains that diagnosis of tendinopathy will follow standard history and examination. An ultrasound may be useful to help differentiate between, for example, peritendinopathy and reactive tendinopathy in the early stage. In the latter stages of tendinopathy, the grossly adapted structure of the affected tendon is likely to be more obvious. Patients with tendinopathy often describe increased pain after rest, for example, initial weight bearing in the morning. The sports therapist should take their time to carefully assess active, passive and resisted movements, and also perform muscle length tests. Visual inspection for swelling and thickening, bilateral comparison and specific palpation, including local thumb or fingertip compression, and shearing and gliding for pain provocation using your fingertips will provide important information. Crepitus may be evident with peritendinopathy. Functional tests, such as progressing from initial bilateral then unilateral tiptoe standing or heel drops onto more dynamically stressful hopping tests to assess energy storage and release loading, are useful for assessing the Achilles tendon. Hopping and other jump tests may be used to functionally and dynamically assess the patella and quadriceps tendons, and clap press-ups may be used in the upper limb assessments. Numerous authors have investigated interventions for tendinopathy. There's good evidence to support controlled progressive heavy, slow resistance training, Konsgaard et al., 2009, and eccentric training, Johnson and Alfredson, 2005. Keating and Best, 2009, Rees et al., 2009, Sharma and Maffulli, 2005, have reviewed other interventions including the use of deep tissue friction massage, therapeutic ultrasound, low-intensity laser therapy, guided sclerosing injections, nitric oxide, glycerol trinitrate, GTN patches, extracorporeal shockwave therapy, ESWT, pharmacological interventions and non-conservative approaches. However, it's essential to attempt to manage the type and frequency of overload that tendons are exposed to. Although tendinopathies generally do respond favourably to conservative intervention, it's generally recognised that insertional tendinopathies or enthesopathies can be more challenging to manage. The most common exercise-related enthesopathies affect the Achilles, hamstrings at the ischial tuberosity, adductors at the pubis and the quadriceps tendon, and compressive stress can occur at the bony fulcrum just proximal to the TOJ. Alongside the tensile stress of repetitive energy storage and release, excessive compressive stress is recognised as one of the main etiological factors for tendinopathy, and efforts should be made to reduce this during exercise. The sports therapist will recognise that sudden increases in workload, which often occur in training and competition, can easily result in acute tendon pain, and such presentations should be treated as reactive tendinopathy, even when present in an established degenerated tendon. With relative rest and avoidance of abusive overload, which may be enabled by offload taping techniques, amongst other things. Right, that'll do. Cheers.